He's a brilliant ear surgeon, bringing in a lot of new things into the field, as well as bringing a lot of energy into the endoscopic. He's one of the founder members of British group as well. So over to you, Bhav.
Thank you so much, Gaurav. Can you see my screen?
Yes.
Fantastic. Okay, so a very good morning to you all, and many thanks for tuning in on a Sunday morning to listen to these talks. It's truly a great privilege to have been invited once again to participate in this live surgery series. I'm very grateful to Gaurav, not just for the invitation today, but also for his role in setting me off in my career as an otologist and teaching me the fundamentals of endoscopic ear surgery. My name is Bhav. I'm a third-year consultant at London Northwest, and I'm looking forward to sharing my experiences and insights with you into revision stapes surgery. And by comparison to primary stapes surgery, revision is where things become generally quite difficult. And this is because you're often dealing with consequences of altered anatomy. As Gaurav Kansal mentioned earlier, scar tissue and fibrosis, adhesions, previous judgment calls, and occasionally technical errors which you have to correct or account for. So today I want to focus less on the textbook causes of failure and more on how I think about these cases in real life, preoperatively, intraoperatively, and perhaps most importantly, when I decide not to operate at all. So before I start, I just want to make one conflict of interest declaration, which is that I do collaborate with KertzMed on product design and marketing. And in addition, I also have a number of additional affiliations where I work at these places and have these additional affiliations outlined below. So as mentioned, my NHS base is in Northwick Park in northwest London, where I perform stapes surgery regularly, approximately 40 to 50 cases a year. And this includes both primary and revision surgeries, along with offering second opinions as needed. For routine primary stapes surgeries, outcomes across the board, across experienced surgeons, are broadly very comparable. And most literature reports talk about closure of the air-bone gap to within 10 decibels in between 85 to 95% of appropriately selected cases. And primary stapes surgery is not where most of us will struggle. The challenge comes with the uncommon revision case. Firstly, because these are low volume and high stakes, so we don't get as much opportunity to do these cases. And secondly, there's so much variability in revision cases. It could be a displaced prosthesis, an obliterated footplate, a scarred oval window. It could be a dizzy patient. And importantly, revision stapes surgery has a higher stake because these are patients who may have already lost trust in the system after a poor first experience. And because of these complications and challenges, and because the outcomes are less predictable, revision stapes surgery can be very humbling very quickly. Now, I think that whenever giving technical advice, it's important to be transparent about our own outcomes, and these are my own audited outcomes for primary cases. So over the last 3 years, I'm achieving around 94% of air-bone gap closure to within 10 decibels, 98 to within 20 decibels, and a 2% rate of persistent air-bone gap, which is around 20 decibels. The majority of my cases are done with a microscope as a first option, and these are done permeatively under local anesthetic. However, in 20% of cases, I'll use the endoscope if there are particular variations or hazards that would benefit from an improved view, or if specifically requested by the patient. And my default is to use direct piston, though increasingly I'm starting to use vein graft more frequently, particularly if there are variations that would favour this. So my personal primary stapes is comparable probably to most other surgeons, and revisions, so I have much less of a case series. Obviously with revisions, they're less frequent and I'm still fairly early, but I've done around 5 and I've achieved a good result in 40%, so 2 out of 5. One additional patient, I was able to reduce it to within 20 decibels, but two of my patients continue to have a persistent air-bone gap of over 20 decibels. And this is to be expected. Revision outcomes are less predictable in primary surgery. The counselling needs to be very different. And the objective in revision stapes surgery is not always perfection, it's to try and get a meaningful improvement within an acceptable risk profile. So that's outcomes. My strongest belief in any stapes surgery is that your first attempt is the best shot, and by which I mean the first operation in where a prosthesis is actually sited. This is your best chance of achieving excellent hearing results, and it's incumbent on us as stapes surgeons to do all that we can to optimize this attempt. So this is a little schematic diagram just showing you the key things that you should be aiming for. First, you can see that this piston is perpendicular within the stapedotomy, so perpendicularity is crucial. Secondly, you can see it's an appropriate width so that there's no friction against the stapedotomy, and that's very important, reducing friction and resistance to prevent long-term things like displacement, necrosis, persistent airborne gap. You can see the length is perfect. It's not prolapsing into the vestibule, and it's not so short that it's likely going to slip out of the stapedotomy. And also the footplate, you can see that it's not too thick, so that as the stapedotomy goes through, it's not going through a very, very thick footplate. And that's very important for obliterated cases where, as we mentioned earlier today, it's important to thin the footplate down over a wide front before you fenestrate to enable this. And finally, you can see that there is an adequate seal. And this can either be with a blood patch, which I often use, or a vein graft, depending upon the case at hand. So it's really important to try and achieve this kind of an outcome on your first attempt, to optimize the axis and view to get this, maximize perpendicularity and lever effect of the vesicular chain, minimize resistance, make sure the length is perfect, and consider whether a direct piston or vein graft is most appropriate in the case at hand. Now, in a revision case, if the case was abandoned before fenestration, for example due to difficult anatomy, bleeding, operator uncertainty, these patients often do very well when revised, because you're not dealing with the fibrosis and the adhesions and the issues with the incus and vesicular chain, which are slightly more difficult to correct. So these patients typically have a comparable outcome to primary stapes surgery. However, once a prosthesis has been placed, the causes of persistent loss could be displacement or loose prosthesis. It could be due to erosion of the incus. You may need to go back in due to persistent vertigo. You're dealing with vestibular irritation and adhesions and fibrosis in the area. And this is why the first attempt matters so much, to try and avoid these issues from developing before you go back in. Now, not every failed stapes surgery should automatically lead to another operation. And before considering whether I'm going to offer a revision, there are a number of important factors that I think it's important to bear in mind. Firstly is the audiology. Of course, there must be a persistent conductive hearing loss, but an airborne gap should be reasonable and wide enough to merit the risk profile of going back in. So for example, if you've got a wide airborne gap, the potential upside and benefit is sufficient to warrant the risk of revision surgery as compared to primary. And I wouldn't really consider revising a case if they've got an airborne gap of less than 20 decibels. Even 20 to 30 is borderline, but certainly less than 20, I wouldn't go back in. Secondly, thinking about the timeline and time course of the hearing loss. If a patient has some improvement following stapes surgery, primary stapes surgery, there's an improvement in the airborne gap, but it's still over 20 decibels, I wouldn't rush back in to revise them, because over 3 months' time, as the prosthesis beds in and there can be fibrosis and scarring around that, you may get a subsequent improvement and gain, and you may then find that the airborne gap is less than 20 decibels and it's an acceptable result. If they have a period where they immediately had a very good closure of the airborne gap, and then some months later or even some years later it slowly, gradually reduces, this may be due to scarring and adhesions, or it may be due to incus necrosis, erosion, loosening of the prosthesis, and these may benefit from revision. And finally, if you have a patient of fluctuating hearing loss, for example, very good hearing, and then, for example, with pressure or yawning or swallowing, the hearing reduces, this suggests perhaps an overly short prosthesis, which may benefit from revision. Thirdly, symptoms. So usually you might want to revise due to hearing loss, but sometimes, and I have revised a case due to persistent balance issues. And when you're considering it for balance issues, it's very, very important to delineate and differentiate between true vestibular vertigo, so rotatory spinning, versus generalized disequilibrium. Primary stapes surgery is an insult to the inner ear and the vestibular system, and this can often trigger maladaptation and persistent postural perceptual dizziness, 3PD. And revision stapes surgery is not going to help that kind of dizziness, whereas there is a reasonable chance of improving an overly long prosthesis causing vestibular symptoms. Additionally, it's important to consider the patient's expectations. Can they function very well with hearing aids, and do they have a low appetite for risk? In which case, revision stapes surgery may not be the right answer. And as Gaurav and Sachin and Asad just mentioned, the occupation is really, really crucial, because if there is a occupation where hearing, balance or taste are central to their livelihood, the potential downsides can be catastrophic. And finally, who was the surgeon who did the primary operation? It could be yourself or it could be a colleague, and spending some time reviewing the original operative note is important. You want to know what was found intraoperatively. Were there any variations that made it particularly challenging? Was the footplate particularly thick? Was it a type 4 obliterated footplate? And was it reduced over a wide front? Were there things that made access difficult, like an overhanging facial nerve? What was the prosthesis length used, and was that titrated according to, and measured according to the distance from the LPI to the meniscus? Was a vein graft used? And I think that's relevant because, in my opinion, I think using a vein graft in a primary position is protective to the potential cork effect of removing a prosthesis. And if you've done a direct piston technique, there is a slightly higher risk of removing that piston and placing a new one as compared to if this was placed onto a vein graft. And finally, how long did the primary surgery take? Routine primary stapes surgery is quite a quick procedure, but sometimes it can take longer. And if it's taking over an hour, you wonder, was there anatomical issues or factors that made that a particularly challenging case, such as a floating footplate, a fractured footplate, etc. And finally, and quite importantly, it's important to consider the primary surgeon and where they were in their learning curve, because an honest abandoned operation from an early surgeon is fine. It happens to everyone, and the chances of success in revision are favourable. Whereas if it's a patient who's had multiple revisions or a repeated failure from an experienced colleague, at that stage you have to leave the ego at the door and recognise that the chances of success for you in your hands may be limited if a talented colleague has already attempted, and in this situation revision may not be the best option. Now, in terms of preoperative assessment, we talked a little bit about CT for primary stapes surgery, and there's some debate in the utility for revision, but for me I think a CT is mandatory for revision stapes surgeries. And the arguments for, I have seen patients who have had a good hearing outcome and then progressively had a new airborne gap, and a CT has demonstrated ossification of the malleal ligaments and tympanosclerosis, causing lateral chain fixation. And this will not be improved by revision stapes surgery, and knowing that ahead is important. It may help you identify incus erosion and give you an idea of what the pre-surgical plan looks like. If it may identify facial dehiscence or other pathologies, which can be useful in the counselling preoperatively. Now, we mentioned this in the last talk about medical legal aspects. The risk profile for revision stapes surgery is significantly greater. There's perhaps a 5 times increased chance of a dead ear. So it's important to be able to understand how likely that is and what things can be mitigated preoperatively to help that patient make the most informed choice as to whether to proceed or not. There are, however, arguments against using a CT, and there are certain things a CT won't tell you. It won't always tell you whether the prosthesis is sited in the correct position, because fluoroplastic prostheses are radiolucent and you won't be able to see the end necessarily whether it's prolapsing into the vestibule or not. It won't tell you very subtle things like increased resistance, which you can only really determine by palpating the ossicular chain and the long process and feeling how that feels. That's a tactile feel, and a CT won't be able to give that information. There is some radiation that the patient will experience by having a CT that can be mitigated by these newer cone beam CTs, which are lower radiation. And often it may or may not materially change the management depending upon the patient and the aforementioned factors. And therefore, if you know you're not going to go in anyway, a CT is probably not useful. But yeah, that's just something to consider. So I personally use CT as an adjunct not a decision maker, but an adjunct, and certainly something that's very valuable in pre-operative counselling and helping the patient understand the risk profile for them. Now, the second most essential point, I think, for the modern stapes surgeon is that technical rigidity can be dangerous, and it's important to be technically multilingual. But what I mean by that is not being married to specific techniques because that's all you've seen in your training. Different cases require different techniques, and in my opinion, a good stapes surgeon needs to be able to adapt their techniques to the case at hand. I use microscope primarily for my primary surgeries, but sometimes I will use the endoscope because the visualization is superior. And if there are anatomical challenges that limit visualization and I need the better visualization, I'll use that. I do all of my cases under local anesthetic awake, but I think for revision surgeries, the awake surgery is definitely very, very helpful because firstly, it allows you to make an on-table assessment of what's going on and allows you to make an assessment of improvement of hearing following surgery. And that's also valuable for the patient to instill them with confidence intraoperatively that the hearing has improved. The next point is on vein graft. I never actually learnt vein graft during my training, but since being a consultant, I think there is increasingly a value of using the vein graft. Firstly, for reproducing the annular ligament trampoline effect, which Gaurav alluded to earlier, helping create a good seal, and especially for revision cases where there's a fractured footplate or a larger than anticipated fenestration, it can be very, very valuable to create a good seal. And certain cases may benefit and some cases won't. And finally, the prosthesis that you use. So Max did a great talk about different prostheses. And everyone may have their own favorite prosthesis that they like, but some cases may require an alteration to your technique. So for example, if you have too short or too long a long process, you might wish to change to a bucket handle, for example, instead of a crimping prosthesis. You might need to use thinner or thicker prostheses than you might usually. So being comfortable and adaptable with a choice of prosthesis, technique, endoscope versus microscope, I think will only do you benefits. So now I'd like to just show you a couple of videos of different revision cases. Okay, so this is the first case, which it's technically a revision because they had a exploration elsewhere, but it was abandoned and then sent to me, but they hadn't fenestrated. But the issue in this case was an overhanging and bony protuberance of the facial nerve, which the primary surgeon didn't want to proceed with. So I'll show you how we manage that. So this is an endoscopic view. I think the endoscope was very vital in this case. You can see the overhanging facial nerve, which is covered in bone, and it's kind of overhanging the place where I would ideally want to place my stapedotomy. So in these situations, optimizing access is crucial, and taking a bit of extra time to do that is useful. So mobilizing the chorda, removing the chordal folds, and allowing that to stand to be mobile and out of the position is useful. In the first instance, I'm having a little look at that facial nerve bone and seeing, how amenable that is to gentle curettage. And actually, it is quite thick, and I don't want to apply too much pressure on that bony covering. So I elected not to do much more curettage there. And instead, my option was to widen the scutum, reduce the scutum so I get better access, straight line access with my scope and instruments, and instead utilize and reduce some of that promontorial bone. And those of you who have done cochlear implants and cochleostomies, you know how thick that bone is, so you can comfortably remove 0.5 mil or so off that bone and not get into too much issues. So using a bit of the laser onto that cochlea, reducing that promontory slightly just to give you the space that you need. And then we have just enough space to get a normal fenestration. So here to fenestrate, I'm using the laser. As you're probably all aware, you want to create a rosette. So you make your initial laser and then you overlap multiple shots until you create a rosette, feeling against the footplate as to when there's a give, and that determines that you've made a stapedotomy. And here you can see the glisten of perilymph, which you can just see through that. And there's enough of a space between that and that facial overhang. In this situation, I'm using a slightly thinner prosthesis, a 0.4 millimeter prosthesis, which again helps reduce any resistance on its way in. That prosthesis is now introduced through the stapedotomy and secured onto the long process of the incus, and then we reposit the flap. And that procedure is done. You can see the preoperative left airborne gap, which has been adequately closed. And then he then had the right side subsequently a few months later. So that's how I'd address a case of facial overhang or a revision case. But this obviously is quite favourable because there hasn't been a previous stapedotomy performed, and therefore it's essentially a virgin foot plate. This is one of my own revisions, which I'll show you. I revised her second side, so she had her bilateral stapes surgery for otosclerosis, initially on the right hand side, followed by the left. Her right ear had a deep niche, measured 4.75 millimeters between the long process of the incus and the stapes footplate. A similarly long prosthesis was placed in the left side, but unfortunately post-operatively, despite a very good hearing result, she had persistent debilitating vertigo, which was suspected to be secondary to an overly long prosthesis. I begin by harvesting a vein graft. A small amount of lignospan is injected into the dorsum of the hand, and a small incision made over a prominent vein. The vein is then identified, ligated, and harvested for the graft. I found that placing the section of the vein within saline causes the lumen to open up, making it easier to thread a needle through the lumen. The surrounding adventitial tissue is removed to ensure as thin a graft as possible, and following this the vein is opened. I store this within saline to ensure that the graft is moist and fresh prior to application. I then proceed to re-explore the ear, beginning with a bucket-handled tympanomeatal flap. Extra care must be taken when entering the middle ear in a previously operated ear, as the chorda can sometimes be closely adherent to the undersurface. In this case, the chorda remains protected behind its bony covering, as it was not exposed during the previous surgery. Upon entering the middle ear, we can see that the previous prosthesis is placed correctly onto the long process and is sitting within its stapedotomy, as expected. I use the Kurtz meter to identify the appropriate distance between the long process and the footplate, which in this case was measured to be 4.25 millimeters, 0.5 millimeters shorter than the previous prosthesis. The old prosthesis is gently removed using a 0.5 millimeter Shambo hook. The hook is gently placed between the ribbon of the prosthesis and the long process, and rotating this hook 90 degrees clockwise and counterclockwise is sufficient to loosen the prosthesis. This can then be removed. The vein graft is now ready to be sited. I place this onto the stapedotomy with the intimal surface facing outwards and the adventitial sticky surface facing towards the vestibule. Although I don't routinely use vein grafts in primary stapes surgery, I find that they are of benefit for revision stapes, or in cases where a larger than anticipated stapedotomy has been fashioned. There are two principal benefits. Firstly, the sticky adventitial surface of the vein is useful to seal any gaps and prevent any perilymph leak. Secondly, the low friction and elastic intimal surface against which the prosthesis can oscillate, with the elastic property somewhat simulating the annular ligament of the footplate. I find the endoscope to be particularly helpful when placing this, as it allows clear visualization of the footplate and to ensure it has been covered circumferentially. The correctly sized prosthesis is then introduced and placed on top of the vein graft. For revision cases, I also use a slightly thinner prosthesis, 0.4 millimeters in diameter as compared to 0.6 millimeters. This can be trimmed to the desired length, in this case 4.25 millimeters. A thinner prosthesis is desirable as firstly it accommodates the thickness of the vein graft and thus reduces any resistance at the footplate interface. Once the hook of the prosthesis is engaged onto the long process, I crimp this slightly with a single shot of the laser. This partially crimps the ribbon while keeping it loose enough for me to mobilize it towards the distal end of the long process, which is a more mechanically optimal location for this, and optimizes the perpendicularity of the prosthesis. Performing the surgery awake allows me to now assess the patient's hearing to ensure that she has unchanged hearing as compared to preoperatively. Crucially, I can also palpate the chain and ask the patient in real time if this is inducing vertigo, which would suggest an overly long prosthesis. Once completed, a silastic sheet is placed in situ along with a pope wick to cover for 2 weeks. We can compare the pre-operative audiometry to the post-op audiometry post-revision surgery, which shows a further improvement in the air bone gap closure as compared to pre-op, and the patient's vertigo symptoms have resolved. Okay. Finally, I just want to show you this last case, which isn't technically a revision, but there's dual pathologies, and I just wanted to show you this case because it illustrates well why awake stapes surgery is quite helpful and why the endoscope can be particularly helpful in these difficult to manage persistent hearing losses. So this is a lady who had previous tympanoplasty elsewhere and had a persistent conductive hearing loss. CT was pretty normal, so we did exploratory tympanotomy under local anesthesia, and what we found was the stapes was fixed. When I was palpating the chain, you can see any movement of the stapes, although the lateral chain was mobile, and even as I'm doing this you can feel that it's fixed. But as I tried to down fracture, you can see the entire foot plate has come loose. So obviously this is suboptimal and needs to be managed. So I lasered the superstructure to remove that from the foot plate, and then I put the foot plate back down over the oval window, and then measured this with the Kurtz meter. I harvest a vein graft to place over the foot plate, and then place this over the entire area to prevent any perilymph leakage afterwards, and this will help ensure that the foot plate heals in a nice position. And then I will then place a slightly shorter prosthesis to sit on top of the foot plate and the vein graft, because now that foot plate is mobilized. It's not true otosclerosis, it's probably just fixation from previous tympanosclerosis or ossification of the annular ligament. That prosthesis is put into situ, and at this stage the patient feels that the hearing is better, so she's awake and I test the hearing. She says that's very loud, the chain is moving nicely. But when I reposit the flap, she feels that the hearing is now muffled again. And on closer inspection, you can see that there's a bit of blunting over the anterior ear canal. So again, I lift up the flap, test the hearing is better. But as soon as I put the flap back down, she says there's a problem with her hearing and she can't hear so well. And so there's this blunting which has probably occurred from her previous tympanoplasty surgery elsewhere. So the benefit of the awake technique allows me to recognize that there is this blunting. It was quite subtle, I didn't notice that. And again, the endoscope allows you to get a really good view of that anterior wall. So I was mindful not to do too much because she's had stapes surgery and she's had a flap elevated, so I didn't want to traumatize this too much. But you can see that I've tried to reduce that blunting somewhat. I put a silastic sheet, 2 silastic sheets in place directly into that corner, so to try to prevent further blunting. But I haven't been very, very aggressive in reducing that blunting on this occasion. So I'm introducing 2 silastics right into the apex of that tympanomeatal angle, and then I cut a angled pope wick again to sit in that corner and to encourage that to heal well. I'll show you the hearing test results. So that was pre-operatively. There's a decent air bone gap, and actually post-operatively there's not a huge improvement. There is a bit of improvement at 3 kilohertz and above, but there is still a significant greater than 20 decibel, 15 to 20 decibel hearing loss across the range. So post-operatively, that's what that looks like. You can see some area where the blunting has improved, but there's still an area at the top which is potentially still blunted, and a little bit here inferiorly where there's still a bit of blunting, which may be reducing the mobility of that drum to vibrate properly. And the anterior segment of the drum, the vibration there is obviously very, very important for conduction. So then she had a further revision where it was pure local anesthetic laser to the blunted portion, and you can see over here a little bit of blunting which we're trying to reduce with the laser. I'll fast forward slightly. can see more blunting inferiorly, which wasn't addressed at the first sitting. And again, I place more silastic into that corner to try and encourage this to heal. And on table, she felt that the hearing was better with this in place. And post-operatively, once you take out, you can see an improvement in that blunting, but there's still a little bit up here, to be honest with you. It's not perfect, but it's better than before, I would say. And if you look at the hearing loss, so this hearing test, this is before the first operation, this is after the first operation, and then again after the revision, she had a slight improvement, but they still have an ongoing around 20 decibel airborne gap. So this was a difficult case. I wasn't able to close it within 20 decibels, but they were certainly better than before surgery. And obviously there were multiple issues and challenges with this case. There was the foot plate that had come loose, as well as the blunting. But by adapting the technique and addressing each of these in turn, we were able to get a satisfactory result for the patient. Okay, so when to decline revision surgery. So as surgeons, we often focus on what we can do technically, but maturity in revision stapes is knowing when not to operate. And I personally generally avoid revision when a hearing aid is working well, the airborne gap is less than 20 decibels. The time course suggests that there was an immediate minimal improvement, or that they've had prior revisions and they've not subsequently improved. If they've got isolated hearing loss with no vestibular symptoms, and it's a mild hearing loss, then I would decline revision. If the patient has excellent hearing aid benefit, it's their better hearing aid, or they have unrealistic expectations, poor risk understanding, or demonstrating that the risk understanding is suboptimal, then I wouldn't offer it. Finally, if the previous surgeon was an experienced primary surgery and there's unclear cause on the basis of the operation note as to what could have been the cause, these cases are unlikely, in my hands, to improve subsequently. So to conclude, the first attempt matters enormously, and we must do all that we can to optimize the first attempt. Patient selection is critical. CT is very, very helpful, but it doesn't replace your judgment, but it is very important preoperatively for the risk counselling. Technical flexibility is essential, and being able to have a variety of different techniques to utilise to the case at hand is important. And finally, it's very, very important to know when not to revise stapes surgery. Thank you very much, and I'm glad to take any questions if you have any.
As always, excellent talk, excellent video. The most scary point when you're doing stapes surgery and your foot plate starts moving and you're done fracturing it, and how to manage it. It was really well demonstrated. Brilliant. Alam, you wanted to ask something. You raised your hand.
Yeah. First of all, do you think when you do a revision surgery, do you need to freshen after you remove the prosthesis, do you want to refreshen the fenestration in the foot plate of the fenestration from the previous prosthesis, if there is any fibrous tissue or anything like that? Because I think that sometimes there is new bone formation and it becomes really slightly tight. So sometimes we may need to freshen the edge. The other thing is regarding the very nice case, the video the last case actually. But I think that with the airborne gap, which was there from previously, it was mainly due to blunting from the beginning, and it was the cause of the main problem. I think that the foot plate was there is not much otosclerosis there. Maybe it's fixed because of the ligaments of the malleus itself gives a sensation that there is a fixation of the stapes, and the blunting was the problem from the beginning. I know blunting is very difficult to deal with as a surgeon. Regarding may need multiple attempts of doing laser, and sometimes maybe doing a graft or something to try to prevent it. But but very nice presentation. Thank you.
Thanks so much.
Thank you very much.
The best thing was that the bone conduction was absolutely normal even after that much.
Absolutely. So to answer Ahmed's question, so do I refresh the margins, refresh the fenestration? Not always. I think it depends upon what you see. So, for example, in that case, where I revised my own case, you could see that there was a nice cuff around the prosthesis, and through that cuff, you could see a corridor into the vestibule. And her primary issue was vestibular symptoms. So, in that situation, I don't always freshen. It depends upon what you're seeing. So if you're seeing lots of fibrous tissue and you're not convinced that your stapidotomy is wide enough to accommodate your piston without causing resistance, then it probably is worth widening it. But as mentioned by colleagues previously, you got to just be quite careful, because just underneath that is the neuroepithelium of the vestibule, and over trauma and laser in that area can heat the vestibule and cause cochlear issues. So a case by case basis, and the other question related to the last case. So I think you're right. I think blunting was probably the main issue in this case. That being said, on the exploratory tympanotomy, the stapes was very fixed when I palpated it, and if you look at the stapes footplate, it's very rare that you see it out like that. But if you look at the annular area, the annular ligament almost looked ossified. It was very thick peripherally. There was fixation of that stapes. So I think there was dual pathologies, but it just had a very thick ossification of the annular ligament, as well as the blunting. So there was an improvement in hearing on table, because we had on table the ability to hear them. After I replaced the prosthesis, they felt that the hearing was better, but the problem was when I put the flap back down, the hearing became more muffled. So better than before, but not quite perfect. So that tells me that there probably was an ossicular issue, but also blunting. And as you say, blunting is very, very difficult to correct, because once that area becomes less flexible, it's very difficult.
Asad?
Hi, Bhav.
Hi.
Fantastic presentation. Really, really, I mean, it's a testament to your amazing training. Beautiful cases. I've had one of those, like your stapes footplate, where blunting of the edges. And in my experience, in these cases, if you divide the anterior ligament, you fray the malleus, and if you're able to rotate the malleus and bypass the incus, you do get better results, because what you're doing is you're shortening the ossicular chain and reducing any fixation with the incus in the attic or any of the ligaments. So I've had only once, maybe it was a fluke, but I divided the anterior ligament because it frees up the area of the malleus where you have blunting anteriorly, and rotate the malleus, and that actually helped and improved. It did not completely close the airborne gap, but it was improved by about 20 decibels.
Fantastic.
So it may be,
That's a good idea.
if you are brave, maybe if you want to be brave enough to go in again, it might be an idea. It might be an idea to divide the ligament and see if that helps. So yes. The second, I have one question for yourself. I was trained by someone who used to use vein graft. So my initial few surgeries were with the vein graft, and then I found it fiddly, so I gave up. My question is that in your revision case, you used the vein graft, and actually there was no perilymph leak you could see, and you had a really nice corridor and a beautiful sort of a channel which was pre-delivered with some scar tissue around it, which essentially means that there is natural healing which has taken place. Why did you opt to use a vein graft in the second case? I just want to learn myself, because
Of course.
it was done beautifully without any shadow of doubt.
Of course, no, that's a really good question. And I think, yeah, it's a really good question, because I agree, one could have probably got away without using a vein graft, because I wasn't concerned about an overly large fenestration or perilymph leakage, and if I had just put one back in, it probably would have been fine. Increasingly, so my training didn't involve vein grafting, and I kind of been inspired by looking at some colleagues, particularly Ashim, who does use a lot of vein grafts, and the theory is pretty decent in terms of the elasticity and encouraging the high frequency hearing and encouraging transmission of high frequency hearing. So I quite like the theory behind it. And in this particular case, I had a vein graft initially because I wasn't sure what I was going to see when I lifted it up. and I took the prosthesis out. Because I harvested the vein graft before going into the ear. So I wasn't sure whether it was going to be some leakage, etc. or not. But when I looked inside, I felt that it looked nice. And if I could have added some extra elasticity by putting a vein graft in and putting the prosthesis, a thinner prosthesis on top, maybe that would have helped. But thankfully for this patient, her hearing actually got better following the revision. Whether that's due to the vein graft or whether that's due to an appropriately sized prosthesis, I don't know the answer to that. But in revisions, I generally favour a vein graft because, again, the other point is anything that prevents that corking effect. So if you have a primary prosthesis, a direct piston into the vestibule, and then you take it out, usually you'll be fine. But there are sometimes there's a potential risk that as you pull it out, you're causing pressure into the inner ear and traumatize the inner ear, and you can get dead ears. And I've seen that happen to colleagues. Whereas if you have a vein graft and you put something on top of that, you've already got a natural barrier that protects that neuroepithelium. So even if you take it out, you're going to be pulling against this and not a direct communication into the inner ear. And therefore, if there's a chance that you may have to re-revise it in the future, that was the other reason to put a vein graft in.
Excellent presentation, brilliant surgery.
Thank you so much.
Really, really impressive. I mean, my one or two very limited experience of revision surgery is, and I don't do majority of the surgeries under local, but for various reasons I had to do a few. And when I'm removing the prosthesis, the previous prosthesis, if whilst removing the prosthesis, the patient is getting nystagmus or feigns dizziness, that is when I know that actually the fibrous tissue is not dense enough and you're getting the corking effect. However, when you remove the prosthesis, and actually if the patient doesn't complain of dizziness, or they don't say that, oh, I remember one patient who suddenly jolted on the table because she said, I heard a blast in my ear. And that, again, made me feel that actually it's quite weak down there. That was my experience, and those were the cases where I used the vein graft. But obviously, there's always to learn, so thank you for the excellent presentation.
That's a really good point. That's a good idea. On table, if they're getting vestibular symptoms as you're taking out, that's really valuable feedback. I totally agree. One other point I just wanted to make is that for any revision surgery, I always give 3 days of prednisolone, both intraoperatively and 3 days at 30 milligrams with PPI cover, just because I recognize there is more trauma when you're revising.
Yeah. Thank you. Thank you, Bob. Nice to see you and nice to meet you.
Nice seeing you again. Thanks so much.
Right. After that excellent talk, we have got now Asad.